All right. So first, I have no disclosure, no conflict of interest related to this presentation, and have a couple of objectives that we'll try to discuss today in our presentation today, which is first, we're going to be trying to discuss the historical background of both melancholia and catatonia and the interface between both concepts from a historical background. Second, we're going to have some clinical vignettes here that highlights the overlap between catatonia and melancholia and describes identifiable or index symptoms that might represent this overlap. And third, we're going to examine the role of GABA agonists, including lorazepam and other medications in the treatment of this variant of severe depressive disorder. And again, this topic, talking about catatonia and melancholia, catatonia has always been considered as, a motor disorder or a motility psychosis based on the historical literature. People have focused on motor presentation. If you go and look at the current DSM criteria for catatonia, they describe catalepsy, waxy flexibility, rigidity, mutism, posturing, and even like you go with the Bush-Francis scale, they even look at some of the motor presentation or behavioral presentation, Gaggen-Halton, like it's mainly focused on motor. Yes, there might be some cognitive presentation, such as perseveration, or even sometimes like speech-related verbigeration, but the main focus has always been motor. Historical background and historical literature discuss some overlap with mood disorders, and only limited literature describes some overlapping mood presentation related to catatonia. If we go over the literature first, for both conditions, for both melancholia and catatonia, we go back all the way to Hippocrates. The term, where the term melancholia came from, it came from ancient Greek, and it reflects dark bile. And during the times for Hippocrates, they focus on the role of body fluids and how they influence the mood, how they influence basically personalities of people who had were described to have personalities related to red blood. They were fun, very volatile, happy to kind of engage with people. People who are bitter and very firm used to be kind of related to kind of yellow bile. And the concepts of different fluids of human body had a relationship with illness. So the fluids at that time, they were considered like red blood, yellow bile, phlegm, and dark bile. Dark bile, the concept of depression at that time was related to dark bile, where basically there is an imbalance where dark bile tend to predominate over other fluids, and that tend to cause depression. So Hippocrates described that patients with melancholia at that time had poor appetite, abulia, sleepiness, irritability, agitation, fear, and despondencies. And he used the term above all fears and sadness. And this is exactly was a prominent term. And as we focus, this seems to be a little bit similar to what we know nowadays as major depressive disorder based on the CGCAPs, but with a prominent focus on the vegetative symptoms and even the severe symptoms of psychomotor symptoms. You see the agitation, you see the irritability, you see the sleep, and the poor appetite. One of the followers of Hippocrates that then, came, which was Galen. He followed the same concept of Hippocrates, but on top of this, he added that people with melancholia tend to have bizarre, fixated ideas and behaviors. And these seems to be somewhat consistent to what we know nowadays as we focus on the content of the thought, so similar to delusions, but also like as we're talking about the fixated nature of these thoughts, this is similar to what we're going to be discussing later on with the focus on rumination and perseveration. Subsequently, we move all the way to the 18th century. Several authors started to recognize catatonia here and also describe melancholia and some of the overlapping between these presentations. This quote described a state of patient with melancholia, severe state of depression, but now as they're focusing not just only on the mood component of severe depression, now we're focusing on the cognitive aspect of it, where there is a significant slowness of all mental activities. We're talking about the thinking speed, and attention, focus, ability to plan, organize yourself. There's a significant slowness of all these mental activities among patients with depression. So they call these patients acute dementia, and the term stupidate came later on by other authors, such as Bellinger. He described that some patients with melancholia had a state of mental stupor, but then also added some of the motor presentation that he saw among patients with severe depression and melancholia. people were not using the term depression at that time. The term melancholia was prominent. The term melancholia, in its classic way, used to describe the classic depression, but there were more that, as we're going to be discussing later on, there are many more presentation of melancholia that tend to reflect other mood presentation, as we see in mixed mood disorders. As we go again to stupidate, the focus was on severe state of mood symptoms, severe depression, but now they're adding more motor presentation: stupor, fixated eyes, facial expression of astonishment, indifference, and mutism, which is, this correlates with a lot of what we know now as some of the features we see in catatonia, such as the staring, even that astonished look, the indifference, mutism. These are features it's captured right now nowadays in both like some of the DSM criteria, but also a lot of the diagnostic scales. He named this condition as astonished melancholy. Kalbam, who is known to be the father of catatonia, the person who wrote most of what we know nowadays about catatonia, from his monograph in 1874, he had a lot of work in his early work. He described patients with catatonia, but he also described that these tend to happen among patients with classic melancholia or following patient or in the course of mania, just following mania, or even in transition between severe state of depression. He noted that these patients with melancholia suddenly develop these astonished look, these frozen look given to them. And they started to develop some of the motor presentation where they became immobile, they become stuporous, they're staring, they're not interactive. So he focused now like these are motor presentation of this severe state of depression, and he called it melancholia attonita, which is similar to some extent to the stupidate concept given before. He stressed again, this state of melancholia attonita does not come out of nowhere. It usually follows the course of either mania or melancholia. And again, he related this, the state of symptoms of catatonia here to melancholia. They're correlating with each other. It happens during the course of melancholia. It happens during the course followed by mania. And the hallmark of this presentation was that astonished look. He described that melancholia attonita, the state in which the patient remains in taciturn or completely mute and immobile with staring, absorbed expression, gaze, fixated in space, with an apparent complete loss of will, no reaction to sensory stimuli. Sometimes the symptoms of waxy flexibility completely develop, as in catalepsy. Sometimes of a mild degree, but recognizable. All in all, these patients give the impression of the deepest mental pain or being frozen after a great fright. Again, highlighting this is a lot of description of these patients of catatonic features: the staring, the waxy flexibility, catalepsy, immobility, mutism, but among patients who had already severe state of depression or melancholia, classic melancholia. He called it initially melancholia attonita. Later on, he stated that some of these presentation interpreted, it can be seen at a state of melancholia. And the hallmark here was an abnormal state of motility or motor movement. He initially stated that when those patients with classic melancholia develop that astonished look, they change from classic melancholia to become either melancholia attonita, or later on he used the term catatonia. And that hallmark, the difference, is just basically that astonished look. Once they had that astonished look, they crossed that border from being melancholic to catatonic. That border at some point was called the Kalbam border. Again, this is from Kalbam. Many authors who came after Kalbam, later on as we're going to be discussing, only focus on the motor components of catatonia. But one of the authors recently, I think it's Northoff, is the only scale that tend to focus on some of the, not just behavioral manifestation of catatonia, but also affective symptoms of catatonia. And this is exactly in his scale, or in his paper for the scale, he described like several affective manifestation of catatonia. Other authors who came after Kalbam, this is exactly where the focus on motor presentation started to happen. Karl Wernicke joined Kalbam in his conclusion that there's a state of akinetic motility problem or akinetic psychosis here, but now the focus started to distance a little bit from focusing on melancholia or mood symptoms to focus mainly on the motor symptoms of these patients. And the term akinetic motility psychosis started to emerge and to become very common. during that time. And they believe that there is actually pathology in the psychomotor path. This is exactly when they started ignoring the affective component of the syndrome. Subsequently, Kriplin, who came after Kalwa around the same time, like around the 1890s, this is exactly, I mean, he had a lot of contribution in the field. His major contribution in the field is dividing several psychiatric disorders based on the course of their illness. This is how he divided dementia precox, catatonia, and then at that time also catatonia precox from manic depressive illness based on the course. The course of manic depressive illness or mood disorders tend to fluctuate with recurrence to baseline, as opposed to dementia precox, where basically there is a continuous ongoing deterioration that tend to happen. With the absence of treatment to catatonia at that time and the overlapping similarities to some of these, excitement, agitation, disorganized behavior, the word I truly hate because it just basically does not describe anything. It's resembled more the dementia precox. So based on the course of the illness, according to the level of information they had at that time, they connected catatonia more to schizophrenia or more to dementia precox, and ignoring the complete correlation that it had with melancholia. And similarly, this was described by Kalba just recently, about 10, 20 years just before Kriplin, but it got completely. And again, even that the thinking behind this was accurate based on the information they had at that time is completely wrong. And it's unfortunately, this dominated the whole, psychiatric field all the way to the DSM-5. The first edition of DSM-1, 2, they considered any patient with catatonia to be schizophrenic. DSM-3 and 4, it was a subtype. Only in DSM-5 in 2013, when catatonia became a specifier to several conditions. Mainly, we're talking about mood disorder. So again, and all the literature suggested that there is a stronger correlation of catatonia to affective disorder, affective syndrome, as opposed to schizophrenia. However, most of the current diagnostic scales tend to focus on psychomotor syndrome or psychomotor symptoms of the catatonia, with little emphasis on the affective correlation or affective symptoms. The term melancholia that was used before Kriplin was confusing. Now we're talking about, during that time of the field, there were more than 20 different terms, like a melancholia use. Melancholia frontis tend to have, these patients have predominant presentation of, it's affecting their soul. Moria, they're joking, dancing for Salantas, tendency to wander. Some people may have more persecution. Some people might have more melancholia manica. Some people tend to be homicidal, aggressive. So depending on the hallmark of their presentation, they give it a different name. And they came up with more than 20 different melancholia. The classic melancholia was called classic melancholia. But that became confusing because this is not systematic. One of the additions that Kriplin had at that time was trying to get rid of the term melancholia. And instead, he described mixed affective state based on domains of function. These domains were the intellect, mood, and psychomotor activities. So there is a state of excitement that tend to happen in either one of or all of these domains, or a state of inhibition or stillness that tend to happen in some of these domains. So when they all go up, your mood is up, psychomotor activities and volition are up, intellect are up. This is the classic medium. When everything is down, like intellect, mood, psychomotor activity, volition, everything is down, this is a classic depression. But in between, you can have some of these symptoms going up and down. So this exactly in a systematic way, he described these variants of affective disorder or mixed affective disorder with depressive mania, excited depression, unproductive mania, manic stupor, depression with flight of ideas, inhibited mania. And if I wanted to focus on any of these presentations, I wanted to focus mainly on excited depression and depression with flight of ideas, as we're going to be talking about them later. And later on, the term melancholia that got lost. Nobody's using melancholia nowadays. If I ask you guys, does anybody use the term melancholia in their description of depression, even that it's currently present as a specifier in the DSM? And the answer would be less likely because it's very non-specific. What is it? The term, and before that, in the DSM-3 era, people use the term endogenous depression versus reactive depression or psychogenic depression to describe exactly, there are two different forms of depression. Endogenous tend to be more usually severe, and tend to have biological basis. People tend to have family history, and they tend to respond better to medication as opposed to reactive or psychogenic depression, which is basically reactive to life stressors, and they tend to kind of respond well to psychotherapy. The term melancholia used to be included under the endogenous depression, including and basically to highlight that it's a severe form of depression, tend to have significant psychomotor symptoms here. One of the authors in the 90s, all the way to the beginning of 2016-17, his name was Kokopoulos, a Greek psychiatrist who worked in Italy. He worked mainly among patients with agitated depression, and he focused depression is not a homogeneous illness. Some of these features, as we discussed, from the model described by Kriplin, tend to have different presentation, and he focused mainly on this agitated state of depression. He used the term melancholia agitata or mixed agitated depression to highlight that there's a variant of depression characterized by increased psychomotor, agitation, inner excitement or excitation, along with severe depression, aggression, significant mood lability, rage, anger, inner tension, as opposed to classic melancholic state, or basically sadness, as opposed to psychomotor retardation, anhedonia, and lack of energy, anergia. The reason why he characterized this form of depression, that he realized, because it happened now in an era where we have access to treatment, he realized that these people either tend to have poor response to antidepressant, or even they get worse to antidepressant. So based on the response to treatment and based on their characteristic presentation, they can get worse with antidepressant. And instead, these patients tend to respond well to ECT, antipsychotics, some of the mood stabilizers, anti-epileptic medication or lithium, but also he added also to benzodiazepines. He tried to include this variant of depression into the DSM-5, but this, his plan did not go through with the DSM. We'll go back to melancholia to see exactly how the DSM adopted melancholia or melancholic depression. So for DSM-3R, they demanded that the patient would present with at least 5 of the following, and they had 9 criteria. First, loss of pleasure in all or most activities. And I would agree with this, but this is also present in CGCAP's depression, right? The regular state of the major depressive disorder. Lack of reactivity to usual pleasurable stimuli. That's also present in the regular major depressive disorder. It's not different. Depression that is usually worse in the morning and now an early morning awakening, and this tend to highlight sometimes the correlation with cortisol cycle here, and disturbance in the adrenal pituitary adrenal axis. Now, this is exactly becoming more interesting here. This the marked psychomotor retardation and also agitation. People sometimes tend to forget about the agitation part of it and focus on the retardation. But marked psychomotor retardation or agitation, significant anorexia or weight loss, and others. So basically, now we're talking about no significant personality changes before this first major depressive episode, one major previous depressive episode followed by a complete nearly remission, and finally, previous good response to previous or to previous or adequate somatic treatment medications as they did. Things changed with the DSM-4 and DSM-5. Again, what we're currently using is these criteria. First of all, they demanded to have one of the first two, loss of pleasure in almost all activities, lack of reactivity to usually pleasurable stimuli. So these became mandatory. But they're not specific. You can get this also in major depressive disorder. This is how can you tell the difference between this and what you see in major depressive disorder? And I struggle with that. But then they demanded to have at least 3 of the following, right? Lack of reactive, depression, which is usually worse in the morning, early morning awakening. So again, reflecting the cortisol kind of changes, marked psychomotor retardation or agitation, significant anorexia, excessive or inappropriate guilt. Now we're getting into the thinking process, mainly either thought fixation or even delusion or both, and distinct quality of depressed mood different from grief or loss. That's not specific enough. The issue that people got into these criteria, yes, they might be better than the previous one in the DSM-3 era, yet they're not specific. You have depression that is worse than the usual. What does that even mean? People struggle with that. The problem came later on because we know people with severe depression, especially the significant and the worsening of the psychomotor symptoms, the more likely they're going to respond to treatment like ECT. When they took this criteria and tried to see exactly, can that predict the response to treatment with ECT? Unfortunately, it was not. So that's why like these criteria got criticized by Fink and Parker. Max Fink, I mean, he is a leader in the field as he talked about melancholia, catatonia, and ECT. And Parker, he wrote a lot about patients with agitated depression, melancholia and agitated depression. They both criticize the first two criteria not being specific enough, and they don't predict the response to ECT. Parker, on the other hand, said basically these vegetative symptoms, as we focus on the psychomotor agitation, the psychomotor retardation, the sleep, the appetite, these vegetative symptoms, they tend to predict the better response to treatment. So these are becoming the focus. They should be the core symptoms for what we call melancholia, as opposed to not being able to differentiate this from major depressive disorder. Max Fink, on the other hand, and also working with Parker, they kind of suggested basically a different model for how they should define the term melancholia. So they suggested it's a clinical syndrome that is characterized by some laboratory changes, highlighting that it's characterized by signs and symptoms of unremitting gloom, which is a stronger word than just depression, psychomotor disturbances, leaving it open between agitation and retardation, and anhedonia, and then defined by a laboratory test, dexamethasone suppression test, and verified by treatment response to tricyclic antidepressant and electroconvulsive treatment. Unfortunately, nowadays, nobody's using the dexamethasone suppression test any longer. And in the past, it used to be a good, actually, biological marker to reflect severe state of depression, not major depressive disorder, but severe state of depression. One thing that both Fink and Parker added, here, that patients with severe depression and catatonia, they are melancholic in nature. With severe depression and psychotic features, they're also melancholic. Yet, I mean, it was not part of his model for definition, but he stated, look, whenever you see catatonia in patients with melancholia, we're talking about like in patients with severe depression, this is melancholia. Like I mean, also psychosis, catatonia. So, this is some background about the term melancholia from basically the Greek time all the way to the current DSM state and how we're using it. We're going to be moving a little bit to discuss some of the clinical vignettes of patients we treated. I mean, in the inpatient, I treated all of these patients, and we treated more, but we chose these 6 cases because these were the cases we published in the paper. These cases, 2 of them had major depressive disorder as from history, and 4 of them had bipolar disorder by history. All of them had either a lack of response to antidepressant, but some of them actually had significant worsening of symptoms of depression and psychosis the moment we added antidepressant to their treatment. And this is similar to what Kokopoulos mentioned. You give these patients antidepressant, they get worse. All of these patients showed significant psychomotor and vegetative symptoms, significant indecisiveness, and significant perseveration, as we're going to be talking about, or rumination. I mean, and all of these patients had immediate reversal of symptoms, resolution of symptoms within a matter of hours to a day after we gave them lorazepam. And basically, the symptoms recurred back immediately following discontinuation of lorazepam in a clear on and off fashion. So we'll go with the first case. The first case was about a 61-year-old female with no significant systemic medical history and a history of major depressive disorder or psychotic features. She had multiple admissions with this presentation. Every time she comes to the hospital, they give her a combination of antidepressant, antipsychotics, and it takes a while. But in this admission, she presented following a suicidal attempt by trying to stab herself. And again, trying to stab yourself is a very serious and aggressive way where you try to end your life. Most people sometimes, they will try to do something like an overdose, but stabbing, this is serious. Symptoms of depression have been worsening for the last 4 months before presentation. She was previously in the past maintained on a combination of olanzapine, an antipsychotic because of the repetitive nature of the psychosis, sertraline, 100 milligrams, and alprazolam. And the alprazolam was given in an on and off nature. So that reflects to you, even before you see the patient, that there's some level of anxiety, maybe irritability going on with this depression. So this patient presented with depressed mood, anhedonia, increased psychomotor agitation. She was restless. She was unable to sit still. And she was not sleeping at all. She was staying up all night, will sleep only for 2 or 3 hours. I remember, she said she lost almost about 30 pounds within a matter of 2 months. When we saw her initially, like we noticed other features, just not just the depression. She was mute. We were talking to her. Occasionally, she would not respond at all. There was significant staring. There was stop blocking going on too. There was significant indecisiveness. Ask her to sit down, and she was just basically unable to make a decision. We'll just go back and forth, and like unable to execute like any decision. Yet, when we told her, "Can we talk?" She said no, but she will come back again to us. And thing in a non-contextual way. Can you ask her what's going on? No, no, no. And then she will follow us. Can I talk? Yes, no. And like it's very, very non-contextual where she's refusing engagement. And there was repeated crying spells. There was notable fixation on her husband's health. She believed that she caused her husband to have cancer based on a previous sexual encounter. She was the one who was causing this to him. It was very delusional in nature, but the repetitive nature of it, that she kept repeating this in every encounter, was very marked. And she believed that she's going to become homeless, despite that they had enough financial resources, that they're not going to go homeless. And despite reassurance, she kept repeating this over and over, more like a nihilistic delusion. Again, we diagnosed her with severe major depressive disorder with psychotic features, but again, based on the mutism, staring, motor indecisiveness, negativism, this seems to be more catatonia. So we also, like, I mean, the initial Bush Francis catatonia scale was 12. We started her initially on olanzapine 2.5, citalopram 10 milligrams, but we also added the lorazepam for catatonia at a dose of 1 milligram twice daily. Within a day, the catatonic symptoms, the staring, the indecisiveness, the perseveration to some extent, all these symptoms, not eating, not drinking, withdrawal, this all improved. However, she remained somewhat restless, and she continued to remain fixated on the fact that her husband might have cancer because of her, but not at the same, not with the same severity. It continued to happen, but way much better. So at that time, she still was psychotic, but with improved. We decided that it might be better to increase the lorazepam and see exactly if these kind of, remaining catatonic symptoms would improve. We increased the dose of the lorazepam to a total of 5 milligrams, 2.5 twice daily. And what we got surprised, even the delusion, the psychotic symptoms of this presentation of depression, not just the catatonia, the psychotic symptoms, the delusion, improved with the lorazepam. We never touched the olanzapine. It was still at a dose of 2.5. Now, after she got better, we're putting her on a dose of 5 milligrams. She was not sedated. She was not tired. She was not confused. She was not, like, unsteady. But she got concerned about being on a benzo long term. Both of her and her families. They asked us if we can taper her off lorazepam and stop it now that she is better. And we thought basically, we didn't think like it was only the lorazepam that did this, which is olanzapine. So we said, yes, we reduced it, stopped it gradually, and she was fine. We planned discharging her, and just the day before we planned discharge, all the symptoms reemerge again, everything again. The psychomotor symptoms, the depression, the psychosis, indecisiveness, the thought blocking, everything came back again just after we stopped the lorazepam. So we had no option other than putting her back on lorazepam. And when we gave her lorazepam, like these symptoms improved. Now, as to be able to be taking her off lorazepam, she was not happy. She still wanted to be off lorazepam. We suggested ECT. We started ECT, and after the third treatment, we stopped giving her lorazepam, and the symptoms never came back again. We spaced out the ECT. She's been coming for outpatient treatment every 8 weeks, and she's been stable. She did not require to be on antidepressant, no antipsychotic, no, like actually antipsychotic olanzapine 2.5 milligrams, but minimum amount of medication, stable for 2 years, coming only for maintenance ECT. And again, the lorazepam here helped us to get her to get better, to consent, to be able to make a decision, to eat and drink, to be reasonable. Yet it was able to help her to get the ECT. We'll move on to the second case. This is on a 60-year-old male with a history of recurrent major depressive disorder who was admitted for worsening of depressive symptoms and suicidal ideation in the context of psychosocial stressors over 3 months before admission. He presented with severely depressed mood, decreased appetite, weight loss of 20 pounds within a matter of a month, reduced energy, excessive guilt, poor sleep, and suicidal ideation. Before he came to us, he was maintained on citalopram, 20 milligrams by his outpatient psychiatrist. And despite that, there was no improvement. Like, he was taking the medication, he was persistent with, he was adherent, yet the symptoms persisted. He initially, we decided to say, maybe citalopram is not working alone. One of the major symptoms he had is not eating, not sleeping. Maybe augmenting it with mirtazapine might be a good idea. So we added mirtazapine 15 milligrams with the hope it might work. And then later on, we noticed that the symptoms worsened. Like, I mean, we're giving antidepressant and we're noticing that the symptoms of depression is becoming worse. Mood is worse. The excessive guilt is worse. Now he started staying in his room. He was not getting out. He was feeling hopeless, that there's no point of living. He was becoming restless and he became delusional. He believed that the police is out to get him there. And basically his apartment, like, I mean, his house is going through demolition. And this is not true. We confirmed this with the family. He was part of a new delusion. So we thought maybe like this combination of two antidepressant is not working. So let's try him on a different medication. Let's go on, instead of escitalopram, with fluoxetine. We added fluoxetine. And during that time, we were discussing ECT, but he was declining. He didn't want to do ECT. Now, as we added fluoxetine, these delusions became intense. The self-isolation in his room became worse. He stopped showering, he stopped eating at all, he stopped drinking, he became disheveled, and now the ability to make a decision became very paralyzed. We told him to take the medicine. Occasionally, he will stay, like, I mean, for 10 minutes trying to think about it and not maybe being able to make a decision, which is different from how he was before. And like with the delusion, holistic delusions, this became intense. He became even more irritable, anxious, and restless. And we worried about him, so we thought, like, I mean, no, we're adding medication that are making things worse. Let's get rid of these medication. Like, try something else. He's psychotic. Let's give him an antipsychotic. So we thought about olanzapine 2.5 milligrams, but because of the intense anxiety, restlessness, we're not even thinking at that time, like, is this a variant of catatonia or a variant of, like, different variant of depression? So we gave him 0.5 milligrams of lorazepam twice daily. The olanzapine was supposed to be given at night. The first dose of the lorazepam was given in the afternoon, within 2 hours, just 2 hours of when that happened. He got out of his room. He started eating. He shaved. His anxiety, restlessness, fixation, delusions, paranoia all went away. He started eating again. He became well in a way that shocked us. It was like, what happened? You don't see such a response in psychiatry, except for catatonia, maybe sometimes for ADHD medication, EPS, but not in a state of severe depression, presumably maybe even treatment-resistant depression. So at that time, we said, like, okay, we're gonna, he got better. We'll just basically was continue the lorazepam after a couple of days. So we'll keep him on the Prozac, and maybe we'll just keep the olanzapine in. A few days after we stopped the lorazepam, the symptoms just came back again. The same kind of psychomotor symptoms of severe depression: indecisiveness, irritability, increase in anxiety, poor sleep, poor appetite, thought like fixation, repeating things over and over, ruminating over a topic over and over, despite like it's the same olanzapine, thinking like this is psychotic symptoms. The only thing that changed is just we removed the lorazepam. So we did put him back on lorazepam, and symptoms improved within a day. Now we thought, okay, what do we do here? We just discharge him on this combination of medication: fluoxetine 40, olanzapine 2.5 milligrams, and lorazepam. Unfortunately, just a few months after, he stopped taking the medicine. But when he came back again, we just give him back the medication, which helped him to improve. But now after that, we moved on to ECT, and he's been on maintenance ECT for 3 years, doing well. But in that state of depression, in that particular time, it helped to kind of get things more better and improve. The third case is on a 54-year-old male with history of bipolar 1 disorder, was admitted with extreme irritability, paranoia, agitation in the context of medication non-compliance. Now we're talking about bipolar. Had a history of alcohol use disorder, with the last drink being 35 days before presentation. So when he presented to the emergency, there was no suggestive features at all for alcohol withdrawal, at all. But he presented at that time to the emergency with depressed mood, suicidal ideation, hallucinations. He was hearing his parents telling him that he needs to kind of join them by killing himself. Nihilistic, ideas that there's no point of living. It's better that he should kill himself. There's no way out of it. Irritability, poor oral intake, not showering, not taking care of himself. And his labs in the emergency were normal. Like there was no substance, using the urine tox screen here, but marked hyponatremia, presumably at that time, I think from the poor oral intake. When we came to see him initially, the guy was so irritable. Like, I mean, I remember when I met with him, like, I mean, we were sitting on edge. We were just watching what we were talking about with him because he will snap easily on us. And then apologize, but he couldn't help himself. He reported poor sleep, poor appetite, suicidal thoughts. We thought, like, this is depression with psychotic features. Let's give him an antidepressant and antipsychotic. So we gave him mirtazapine, a best medication for somebody who's not sleeping, somebody who's not eating, and haloperidol, again, for his psychotic symptoms. And then we increased the mirtazapine, like, because we didn't see an improvement, we increased it to 30 milligrams within day 3. Unfortunately, now we're seeing the opposite. We're seeing actually the symptoms of severe irritability, aggression, indecisiveness, and fixation rumination becoming more intense. And even the suicidal thoughts became more intense. And now he stopped eating at all, and he started losing weight significantly. So at some point, like we're working on a freestanding hospital, so we thought like maybe he might require to be transferred for IV fluid. But before that, I thought like let's give him lorazepam and see what happens here. Is this more of a withdrawal negativism that you can occasionally see in catatonia? But we're talking about without in the absence of these motor presentation you can see classically in catatonia. The moment we gave him the first dose of lorazepam, within 2 hours, this irritability in mood, self-care, poor oral intake, indecisiveness, rumination, even the hallucination, even the psychotic symptoms, that all went away. So at that time we thought like, okay, like maybe antidepressant might be a culprit in his case. We'll discontinue that. And taking into account like this is a guy with a history of alcohol use disorder, bipolar, it's going to be extremely difficult to have any psychiatrist prescribe him lorazepam on the longer term. We suggested ECT, he declined. So we had no option. I just gave him, haloperidol, 2.5 on discharge, and lorazepam 1 milligram twice daily, and discharged him. Unfortunately, he stopped taking the medication within a week, and within like just a few days after, he was found by his brother in his apartment after he had overdosed. He was taken to the emergency. They took him there and they checked his lost medication, including lorazepam. So they resumed the lorazepam again. And when he came to us, like they described him initially as irritable, edgy, suicidal, panicking, and fixating on topics. When by the time he came to us, most of these symptoms improved. So we suggested ECT again. I mean, he still declined. He didn't want to do ECT, mainly like not from the fear of ECT reputation. So we try, again, I did not want him to be trialed on antidepressant at that time. But this is during the COVID time. So people were out for multiple reasons and coverage happened. Some of my colleagues prescribed him several antidepressants. So someone prescribed fluoxetine, mirtazapine, even trazodone for sleeping, considering that the sleeping was worse. Every single time they added an antidepressant, the same or the next day, his symptoms of intense irritability, anger, frustration, we're talking about the rumination and the significant suicidal ideation, that came back immediately within a day. They can get to a point where they sometimes get scary. One of those weekends, I had to give a high dose just to, try to kind of calm things down. But they came back immediately. So at that time, we tried several other medications. Mainly, we're talking here about second generations, olanzapine, quetiapine, lurasidone. After all, we're talking about bipolar disorder. And these helped with the symptoms. But unfortunately, even with the combination with lorazepam, between olanzapine, lorazepam, quetiapine, lorazepam, there was no complete resolution here, similar to what we saw at a good high dose of lorazepam. We managed to reduce lorazepam here. But every time we reduced lorazepam, symptoms came back again. Now, we spoke about ECT, told him, like, this is not moving, this is not working. He agreed, reluctantly agreed. And he had 7 treatment inpatients. And we got happy, he was planned to come for outpatient treatment. And when we got him to do ECT, we discontinued lorazepam. So we got rid of the headache of prescribing lorazepam to somebody with alcohol use disorder. However, he did not make it to the ECT. And again, he's not on lorazepam. So immediately the symptoms just came back again in no time. And he had a suicidal attempt, required him to be hospitalized. We got into this issue. Now what we use, lorazepam work, but even with lorazepam works, but still, again, we still have to give him lorazepam. And if he's not taking the medication, or even in some of the occasion here, in one incident, we had shortage of staff, and they didn't give him the lorazepam on time. They just waited for 2 hours. All these symptoms came back again. He became irritable, paranoid, refused taking medication, became antagonistic, refused to talk to people. This is COVID time, so he was actually even in COVID seclusion and refused to talk to anybody. At that time, we had to get a code team and get treatment over objection. We did put hands on him to give him lorazepam, and he was angry with us to put hands on him, and he threatened to sue everybody for doing that to him. But after we gave him lorazepam, 2 hours later, he came and apologized for everybody, and actually thanked everybody for trying to help him with this. He got this helped with the symptoms. But now what do we do? Not giving him lorazepam in time, this is not going to work well. So now acknowledging that this is, an overlapping catatonic presentation based on negativism, based on irritability, excitement. In patients with catatonia, do we use other medications here that might have a longer stay in the body? And, some of the off-label use was only zolpidem. So we stopped the lorazepam, given zolpidem, 5 milligrams in the morning, 10 milligrams in the evening. And surprisingly, actually, like there was stability here. There was no ups and downs. We got rid of the Ativan. We got rid of the issue about prescribing benzos. Like to me, it's the same. It's the same, mechanism of action. But to different psychiatrists, they might be feeling more comfortable prescribing zolpidem as opposed to lorazepam. So he did well for 2 weeks. Watched him to be stable. We discharged him on lorazepam 60, zolpidem 5 milligrams in the morning, 10 milligrams in the evening. Pharmacist called us. I was like, "Are you guys serious prescribing zolpidem in the morning?" I was like, "Yes." We followed up with the guy for about a month. He traveled and went to a different state, but we even followed up with him, and he was doing well on the above medication here. All right. The fourth case is on a 69-year-old female with history of bipolar 1 disorder, previously maintained on valproic acid, 500 milligrams twice daily, trazodone 100 milligrams at night, and a newly added medication, duloxetine. This was added about 3 weeks prior to admission for back pain issues. She presented like within short period of time with, again, immediately after they added the medicine, with irritability, in mood, depressed mood, paranoia, restlessness, thought blocking, again, fixation on her medication, rumination about things, argumentative, threatening. This is a significant change from how she was. And we offered ECT when we saw this presentation. She refused. She said, like, no. And she was very antagonistic and very, very paranoid about people's intention toward her. Again, as we saw, like, we checked the valproic acid level. It was not as high, 40 microgram. We thought, like, this happened because of the duloxetine. The first step is just to get rid of the duloxetine. She was started on thyroxine. This is a medication she used in the past. So, I never used it except for this patient. And thyroxetine. And then we increased the Depakote. Again, we didn't see any improvements. And a matter of fact, it was a challenge to talk to her. She was very daring, very threatening, very argumentative, and like very threatening. Like, our internal medicine physician would just walk away from her immediately because how she was really problematic. So at that time, again, we're acknowledging this presentation here, especially with the irritability. We gave her 0.5 milligrams of lorazepam, hoping to help. Again, we're giving lorazepam for an older lady, 69 years old. Following the first dose, immediately all of the above symptoms, again, within a matter of hours, the irritability, anger, intense anxiety, thought blocking, like paranoia, rumination on things, depressed mood, all improved within hours. And after we adjusted the Depakote level, was 68. But again, like everybody who seems to be reasonable, she requested to stop lorazepam. She had concerns about falling, concerns about the habit-forming pattern of this medication. So we agreed. But the symptoms came back again the next day, all the symptoms again. Now we had to put her, like we suggested ECT, but she was again refusing. And now we started the whole process about like we need to obtain a court order for her. She's going to refuse. Meanwhile, as we're waiting to get the court order, as the symptoms became so severe, we gave lorazepam again. Symptoms improved within a day again. Now, we're talking about 0.5 milligrams of lorazepam twice daily, thyroxetine and valproic acid. She, by herself, made the decision that, that's not a big deal to be on lorazepam. She was not unsteady. She was not confused. She was not, having problems with mobility here. So she said, I'll take the lorazepam. I don't think I need to do ECT. And she's been doing well for years on this combination. Case 4 is on a 57-year-old female with a history of bipolar 1 disorder who was admitted for worsening of depression, social isolation, significant weight loss. And again, you guys, as you continue to hear, we're talking about vegetative symptoms, social isolation, more of a withdrawal, similar to what you see as negativism you see in catatonia here. Failure to thrive, similar to what you see in catatonia, similar to the withdrawal, negativism, inability to take care of herself. And this patient had several trials of different combination of multiple antipsychotics, mood stabilizers, with no response. Every time she ends up in the hospital, she ends up there for months and months. Even with different trials of different treatment, it takes a while to make a small dent in her course of treatment. So one of the major thing here, she had a BMI of 18. She refused to eat. She was literally skin and bone. And she was refusing engagement. Every time we came to talk to her, she was like, yeah, fine, leave me alone. Yeah, tomorrow, not today. More like a negativism here and more withdrawal negativism that you can see as a prominent presentation on top of her depression. And, we tried several medications here with limited response. And at one time, I think this is exactly this is the first case that made us think about the whole thing about overlap. The negativism, withdrawal, presentation as a predominant presentation, in addition to the, poor oral intake as a form of withdrawal. I spoke with Dr. Francis. here, and like, I mean, while eating lunch, I was like, could that be a subsyndrome of catatonia here? Like, just based on these two symptoms. He said, what is it going to hurt if we give her Ativan? And we did. We gave her Ativan 0.5 milligrams twice daily. And to our surprise, like within 24 hours, like, I mean, there was notable improvement in her mood again, like not just like like, I mean, not just the interaction, the mood, the depression she had, appetite, socialization. She got out of her room after a long period of time. Now she started gaining weight within, talk about 7 pounds within a week. And we discharged her on a combination of lithium, olanzapine, lorazepam. Again, after she left the hospital, she was not necessarily very adherent to the medicine. She required hospitalization again. But every time we started the same combination, the hospitalization was shorter and the extent of the improvement was better in comparison to her prior admissions. Case 6, and the last case here, is on a 75-year-old female, again, an older, like senior population here, female history of bipolar 1 disorder, was admitted with worsening of depression and suicidal ideation. She was previously maintained on a combination of bupropion, 100 milligrams twice daily, and quetiapine, 50 milligrams. She presented with low mood, anhedonia, poor motivation, extreme anxiety, restlessness. Again, you see the psychomotor excitement, inattention, poor memory, indecisiveness, poor appetite, poor sleeps, poor weight loss, significant weight loss. So prominent vegetative symptoms, motor, cognitive. Quetiapine was increased, as you would see, for any patient with bipolar disorder, to 200 milligrams, and we also increased the bupropion to 150 twice daily. We thought about maybe, we didn't see an improvement, like not sleeping, not eating seems to be a problematic thing here. So we added mirtazapine and increased the dose to 45, and we hoped for improvement. And unfortunately, we get worsening of these symptoms. In a matter of fact, she started becoming paranoid about the staff, suspicious about their intention. She struggled with making simple decisions now. I saw her one time in front of the nursing, like in the medication room. She was holding the medicine, looking at it for almost 15 minutes. And like we tell her, take the medicine. And she was not saying necessarily no, but she struggled to make that simple decision about taking that medicine. Significant or even pathological indecisiveness or ambivalence that was seen on her. So we gave her risperidone, failed, did not work. Now we thought about ECT, and she was saying no. She struggled with making decisions. She was extremely indecisive, and this is not normal for her. Again, we tried to obtain a court order for ECT, but because of the significant severe anxiety, we gave a dose of lorazepam 0.5 that was not even planned for a long term. She got better. Now, she was planned to, like, I mean, we were hoping to get a court order for ECT. Now she got better to the extent that she cleared up. She was not as depressed. She started eating. She was sleeping better. She was able to consent. And this is after one dose. We didn't put it as a standing medicine. So now, like, instead of, like, having to force treatment on her, we kind of, honored her autonomy to consent for ECT, and we moved on with the first treatment. Again, we did not prescribe or continue the lorazepam. She had the first treatment. The second day after treatment, all the symptoms came back again after ECT: paranoia and anxiety, irritability, indecisiveness. And she said no to ECT. So I was like, what do we do again? So now we gave lorazepam standing after the first dose and at a lower dose, 0.25 milligrams daily. Now she agreed after that these symptoms improved again after lorazepam alone, even for somebody who's taking ECT. Yes, I agree, this is the beginning of the course, but that improved for a patient taking ECT and did not interfere with the ECT course. Like, I mean, that might be feared. It's a small dose. After a couple of treatment, we discontinued lorazepam because her family were so concerned about lorazepam. So we discontinued it while maintaining her in ECT. Had 6 treatment, and she demanded to be discharged after the 6th treatment because she was feeling great. Hated to be in the hospital, wanted to have actually her, hair done. And I was like, yeah, fine. Unfortunately, now she was supposed to be coming for outpatient, and in the absence of lorazepam, she just refused to come back 3 weeks later, 3 days later, and she was lost for follow-up, declined further treatment. So these are kind of different cases here who had different presentation. This is more of a summary of the clinical presentation of these patients. All right. So 2 patients with depression, 4 with bipolar disorder, all of them presented with profound depressed mood. All of them presented with severe anhedonia, disabling anxiety, irritability. Second. Psychomotor excitement, agitation, irritability, but also some psychomotor retardation, and sometimes alternating state of both conditions. It's prominent vegetative symptoms, so poor sleep, poor appetite. Now we're talking about the perseveration, repeating things over and over in an uncontextual way. And no matter how you try to kind of reason with them, they kept just repeating the same thing over and over. It's more of a thought process disorder. Indecisiveness, inability to make decisions, it was present in all of them. And then some psychotic symptoms in most of them. Those people responded, like some of them did not respond to antidepressant, but many of them got worse with antidepressant. And this is exactly, some of them got ECT, but all of them got a good response to lorazepam when they got treated. So, just to kind of highlight this presentation. So as we talk about these patients here, and we're talking about, like, is this depression? Is this catatonia? Is it the same? Is there an overlap in between them? That state of overlap was discussed earlier on, as we discussed with Kalba. Kalba mentioned that catatonia does not come out of the blue most of the time. It tends to happen either during the course of melancholia or recovering from mania. So it happens in association with the course of bipolar disorder. Other people, like Taylor, described some of these patients with melancholia tend to present with profound psychomotor retardation. They become stuporous. These are similar, just like catatonic presentations. They can barely respond to internal stimuli, stupor, staring into the space, staring, posturing, stop eating and drinking. Like, these are catatonic symptoms. Can have rumination and anxiety. And this is exactly when it gets interesting. It's the state of rumination, and which can be confused. And again, like that state of rumination and fixation can always be confused with obsessive compulsive disorder. But what he suggested, that the difference between this rumination, what you see among patients with severe depression or melancholia and OCD, that these patients tend to have associated vegetative symptoms and state of severe depression, as opposed to what you see in OCD. Now we're going to talk again about these overlap. Some of these presentation we mentioned here is perseveration. Perseveration is present in catatonia. Perseveration rumination has been discussed also as a feature of depression. It's a common overlap in phenomenology between both of them. The problem that sometimes we come across in psychiatric literature, that we define the same condition differently here. I think I'll have to go a little bit faster with time. So they have, separate definitions that they might sound similar, but a little bit might be different in the wording. Yet these are features that you can see among patients with catatonia and among patients with schizophrenia. In the context of catatonia, is defined as repeatedly returning to the same topic. In context of severe depression, we're talking about repetitive, prolonged, recurrent negative thoughts about themselves, their symptoms, and their problem. These are a thought process issue, has nothing to do with the content. The content can be reasonable, can be irreasonable, can be logical, illogical, can be normal, can be psychotic. It's the thought fixation repetition that is happening in a non-contextual way that makes this perseveration. Other people, like Okopoulos, as we mentioned, he described the state of agitated melancholia to have internal tension, restlessness, irritability, and provoke aggression. So we talk about psychomotor excitement. He also mentioned the term thought rumination here. And this is equivalent to what you see in catatonia with excitement, agitation, impulsivity, combativeness. You see these features. There is a phenomenological overlap between the two conditions here. As we move on to Max Fink and Taylor, they also described the state of psychomotor agitation and also described rumination in these cases. So these are common features that you can see in both condition between catatonia and melancholia. Another presentation that you can see is the pathological indecisiveness. Similar to what we described in some of these patients, they're unable to make decisions, they struggle, they have a severe, significant state of indecisiveness. All of our cases had them. Literature of depression described pathological indecisiveness as a feature of depression, and this goes all the way to the 18th century by Haynor. He used the term abulomania, or indecisiveness, and he thought this is a cardinal feature among patients with severe depression, and those patients tend to present with severe anxiety. And now even they thought about this, when you come to see the equivalent of this in catatonia, the ambitendency, which is more a state of indecisiveness, has been described in the Bush-Francis scale. You go to ambivalence, which was described in the Northrop scale for catatonia. Also, it's just this is a cognitive equivalent to motor indecisiveness, cognitive indecisiveness. You can see this as a feature of catatonia. So there is an overlap in these, concepts in both severe depression and catatonia. So now the question is, there is a historical background that sees, that catatonia and melancholia seems to have a common background. There's a lot of common features in between them. We know that patients with catatonia, they get treated with lorazepam and ECT. We know that patients with severe depression, ECT works. But the question is, does lorazepam treat melancholic depression. I mean, yes, our cases mentioned basically clearly in an on and off phenomena how they responded, but what did the literature say about the treatment and the role of lorazepam or the role of GABA agonist to begin with for the treatment of depression? So we looked at the literature, and since the 70s, it was not uncommon to use benzodiazepine, various benzodiazepines, for the treatment of depression. And they're different groups. We came across several studies. Um, even right now, some of the newer kind of GABAergic agents have been marketed as the new treatment for depression. But there have been several studies in the past between 1960s to the 1990s reviewed the role of several benzodiazepine in treating depression. So as we're going to be talking and mentioning briefly, there are several studies. First of all, the concept of depression at that time varied a lot depending on the DSM criteria. Also, these are different population. Depression is not a homogeneous condition. So these studies occasionally studied inpatient population, occasionally studied outpatient population, occasionally just studied the combination of inpatient and outpatient. Some of them tried to identify melancholic features versus not. And again, melancholic features based on the criticized DSM-3 criteria here. And they were compared with tricyclic antidepressant mainly. They were looking at the efficacy of the treatment, how long does it take to work, and basically tolerability of these medications for comparison between tricyclic antidepressants. And they studied several benzodiazepines. As we know, for the treatment of catatonia, not all benzos work. Lorazepam work. You try clonazepam, does not work. You try diazepam, it does not work, right? Here, they found, actually in these studies, as we're going to be mentioning some of them, that there's a group of benzodiazepine tend to have a better response than others. And these were called the triazolobenzodiazepines. That included medications like alprazolam, Xanax, and adinazolam, and lorazepam. When they studied medication like diazepam, chlorodiazepoxide, they produced very lousy effects. And one of the last questions here, do they produce an effect beyond what you can see for sleep and anxiety? Do they affect core features of depression? And these are the things that they try to answer. We'll go over some of them briefly as we're, I don't want to be short with time. So we go all the way to 1976 here by Fabry. He had a small group of depressed outpatient people. So outpatient, they're different from the patient we discussed in our, case series here. And he found, they used alprazolam at that time. They found 80% of these subjects had significant improvement. And this is not just basic improvement in sleep or just on anxiety. We're talking about improvement in mood, improvement in in mood, energy, motivation, beyond what you can see for the analgesic action of these medications. Schasberg, he looked at different benzodiazepine to see exactly if they are be helpful for the treatment of depression or not. And they found that insomnia, tension, anxiety, the depressed mood, reduced libido, all improved with the use of several benzos as opposed to versus the core symptoms. At some point, just I want to add that actually some of these medication had an approval by the FDA for treatment of depression. We're talking about alprazolam. Nobody's using them nowadays just for obvious reasons. Nobody wants to have an issues with addiction, but they were used at some point. Again, Viner at some point studied limbitrol, which is a combination of chlorodiazepoxide and amitriptyline together to see exactly if it's better than either of them versus placebo. And he found that the patient who had the combination had better response than others. And many of the studies nowadays who study the outcome for the combination of benzos versus antidepressant seem to find the same results. Moving forward, I think Rickles, he started studying alprazolam, Xanax versus antidepressant, tricyclic at that time, imipramine. And he found that those patients who used alprazolam had equally effective response similar to imipramine. And again, mostly among patients with anxious, agitated subtype of depression. Other studies that came after that, we're talking about expanded studies for outpatient multicenter studies that had a comparison between alprazolam and imipramine versus placebo. And again, you're going to seeing the theme here. They either found that alprazolam was better in the first period because they tend to work faster than tricyclic antidepressants, or even as equivalent. Some of them said at the end, after a couple of weeks at the end of their treatment, the tricyclic antidepressant tend to produce a better outcome toward the end. However, when they looked at the tolerability between alprazolam and tricyclic antidepressant, many patients who were on antidepressant during that time, tricyclic mainly, discontinued the medication for, discomfort, side effect, tolerability issues, as opposed to alprazolam. Again, not suggesting, this is not by any chance an encouragement to use benzos for treatment of depression, but more laying the result of these studies and talking about the potential role of some of these GABA receptors in the improvement and the response. Not talking about tolerability, not talking about the bunch of side effects here that can come with these medications here. Adinazolam, again, was studied and it was found to be helpful. This was part of the triad, like azolobenzodiazepines here. And several studies that came after that, but the studies tended to kind of, here, this is a nice study that had diazepam in their comparison, and they found that diazepam was actually very lousy when it came to treating antidepressant effects here, as opposed to some of these triazolobenzodiazepines here. Again, more studies, so just have to go over them a little bit fast in order to, make sure we have enough time. One interesting case series prescribed by this, reported by Khan in 1986, described some patient with severe depression, but prominent psychomotor excitement, agitation, restlessness, and he called them depression with panic disorders. This is exactly to highlight how they were restless. And they were tried on several antidepressants. Every time they tried them on antidepressant, they got worse. Antipsychotic. Some of them they tried lithium and they tried ECT, and they did not benefit until they tried them on alprazolam, and they got a good response. When they took them off the alprazolam, symptoms came back again. And again, as they came across to a point that do we let them just be or die with a severe depression? They left them on alprazolam. They were doing well with no side effects, no issues. And again, we're talking about a specific population. Not everybody with sticky calves depression. They left them on, alprazolam for ongoing treatment here. More studies, including, until the 95s here, talking about the similar results. And until recently, we're talking about, Cochrane intervention review, talking about the role of benzodiazepines and saying that the antidepressant plus benzodiazepine was more effective than just antidepressant alone. So that takes us to, a question here. Is catatonia motor syndrome? Is melancholia just a mood disorder alone? Do those two conditions tend to lay on the same spectrum with just, melancholia or severe depression tend to have the prominent mood component here, and catatonia tend to have a prominent psychomotor and cognitive component here. And most of those patients actually sometimes lay in between. And, talking about, here in these cases, there has been a significant, as we argue with this presentation, there's significant historical background in both melancholia. We're not talking about major depression. We're not talking about major depressive disorder. We're talking about a variant of this depression. Patients with melancholia, in their historical background, in their phenomenology, and in the response to treatment. And as we talk about our cases, they presented with severe symptoms, and these symptoms had prominent psychomotor agitation, retardation, alternating state of both of them. They had some prominent vegetative symptoms. They were not eating, they were not drinking, they were not sleeping. They had significant psychotic symptoms in most of them. They had prominent perseveration, rumination on topics. And that made us think, and when they were treated, most of these patients got worse when we treated them in a similar way to other major depressive disorder. Give them an antidepressant, give them an SSRI, give them any other medication. They got worse. Some of them, they got better as we removed this medication as if it's a poison, similar to how we treat patients with bipolar depression. So they got better the moment within a day when we gave them lorazepam. They got worse when we took the lorazepam away, in a clear on and off phenomenon. Sometimes even when we did ECT in the beginning, some of them did not benefit until we put them on lorazepam. That makes us think exactly is this a condition we can identify in clinical practice here? And based on our cases here, we try to kind of provide some index presentation to what can we suggest as an identifiable presentation for this variant. I know Kokopoulos, try to provide his view about what this could then potentially be. Okay, so these were our kind of provisional criteria for melancholia based on what we think. We're talking about not just, people that provided different criteria for melancholia, they were like, they were criticized for not being specific. And, like, I mean, as Parker mentioned, like the focus on the psychomotor syndrome is key here, but it's since it's key here to predict the response to treatment. So we focused on psychomotor syndromes. And we said basically these patients tend to present with either psychomotor agitation and psychomotor retardation or alternating state of both of them. And as we talk about psychomotor, that can be in the speech, can be in the motor activities. Like, I mean, like we talk about excitement, repetition, repetitive action, restlessness, aggression. Psychomotor retardation manifested as like when you can see it in the speech, in the motor activity, you can see some isolation, you can see withdrawal, you can see poor eye-to-eye contact. And I know, like, I mean, if you want to, like, these are overlapping features you see in catatonia here. Prominent vegetative symptoms. And as we're talking about disrupted and dysregulated oral intake, poor sleep, decreased energy, and fatigue. We're talking about prominent vegetative symptoms here, not just like basically not having an appetite. Those people mostly lost significant, like, I mean, amount of weight, 20, 30 pounds within a short period of time. Some of them will refuse to eat to the extent that, they might neglect themselves. I mean, we had some patients that had actually some, like, their dentation became so poor, they lost teeth, like, because of the significant withdrawal and significant vegetative symptoms here. Perseveration and rumination. And this is, again, we're acknowledging that there is an overlap for how you describe things here. So we suggest that the perseveration is a thought disorder, process disorder, manifested by repetition or fixation in a non-contextual way on a topic, a theme, regardless of the information itself. It's basically you just keep repeating the topic over and over. The topic can be logical, illogical, like paranoia, like, I mean, but again, the repetition in a non-contextual way that makes this different. And literature used both terms, so that's why, like, we're acknowledging this. And then finally, that in the state of indecisiveness, that we're talking about marked indecisiveness. Those people will struggle with filling the menu or making simple decisions. They will go back and forth. They will have difficulties with, like, I mean, asking them to, can you talk to us? And they will be frozen, not being able to talk. You walk away from them, they ask you to come back again, and this extreme state of indecisiveness. So we propose that these are provisional criteria for what we like suggest as basically might be reflective more for this variant of catatonia, or for this variant of the depressive disorder that might have a potential response to benzodiazepine. Mainly, we're talking here to lorazepam. The implication of this is, first of all, some of these patients, like, I mean, because they come with depression, they'll be recognized as a depressive disorder. They sometimes might be recognized as a state of, like, treatment-resistant cases. They try several medications, 1, 2, 3. They hit the mark for treatment-resistant cases. They might get lost. And, like, I mean, who would even think about using, and, like, I mean, stopping antidepressants for somebody with depression? That's the illogical thinking. And even, like, when you tell them, prescribe lorazepam for an older grandma, I was like, are you out of your mind? But the implication here, this might be the only way to go sometimes. And even if you don't want to give them, like, I mean, lorazepam longer term, like, this is exactly, all of these patients tolerated it. In a similar way to catatonia here, like, when you prescribe lorazepam to older people with catatonia, answer is yes, just like it's a different response. In a similar analogy to this, you have a patient with type 1 diabetes and you give them insulin, give them 10 units, nothing is going to happen to them. You get somebody who's non-diabetic, you give them 10 units of insulin, they go to a significant hypoglycemia. Now, is insulin dangerous medicine? No, you have to take it in context here. Is lorazepam a good medication for this population? And this is exactly what we're trying to argue. It's not for everybody, but for a particular population that might have a role here. Not everybody has access to ECT. Even with places like us, we had access to ECT. What if they eat? Like, they're not going to eat. They're not going to drink. They're not going to take care of themselves. What about the significant serious suicidal attempts that can happen in that context? And most importantly, most of these people will try to obtain a court order. What if that can improve their autonomy? What if that can get them to the ECT, improve their autonomy, and then later on we can get rid of the lorazepam? And this became actually the practice that we do. We get them there, and just after they get a couple of treatment, we discontinue lorazepam. And then sometimes we can add an atypical antipsychotic, an antidepressant. So there is a lot of implication that can come out of, like, recognizing this variant of depression. I think this might be an important subject for future studies, but one of the issues we're going to come across when we kind of look for larger studies, we've been focusing right now on only case series, because a similar issue you can encounter with catatonia. It is difficult to do studies among patients with catatonia just because they might not be able to consent, that legal, ethical aspect of it. Here, they have indecisiveness. Remember, like, I mean, how can they make a decision? How can you enroll them if they're unable to? Maybe after. But that's one of the issues that can, affect the plan to do larger studies for this population. But meanwhile, I think, like, I mean, like we start somewhere. And that's exactly what we wanted to highlight. And I'm happy to take questions. Thank you.
Thank you very much, Dr. Mahgoub, on an excellent and thought-provoking presentation. I will start with the first question, as our attendees might raise their hand and ask to be allowed to speak about a question. This discussion really helps contribute to the diagnostic clarifications that our field really desperately needs. It came to mind when you were talking about melancholia agitada and just the presentations of some of the cases you presented, especially the ones that had a clear diagnosis of bipolar illness, mixed states. Some of them had depressive symptoms and had kind of manic-like features with restlessness and agitation. How do you view mixed states, especially since whenever we diagnose somebody with mixed states in the hospital on our acute inpatient units, we do actually include benzodiazepines, and that helps. So maybe we're doing something similar to what you're doing, but without really calling it melancholia or catatonia. Thank you again.
Thank you for this really interesting question. One of the issues for diagnosing mixed bipolar disorder, according to the current DSM-5 TR, or even DSM-5, they basically require the presence of either, full, depressive symptoms and 3 manic symptoms, but they secluded overlapping presentation. So they secluded irritability, excitement, which are cardinal features of this variant. So this exactly, it's the DSM does not allow you to recognize agitada as a mixed presentation. While it is, I agree it is.
Gotcha. All right, Dr. Bonomo has a question.
Thank you, Dr. Mahgoub. I'm glad you're able to be here for this talk. It's very informative, and I'm very happy you made it. So I have a couple of questions, but I think the main one I wanted to ask you about, so, I've been doing some research on melancholia cross-culturally, and one of the things I've noticed is that there's some speculation that melancholia is associated with an increased, I guess, receptivity to somatic symptoms or increased psychosomatic symptoms. Is that something you've noticed in any of your cases of melancholia? Do you think that that's relevant to like the ruminations that kind of plague it, or is it just kind of maybe a different type of melancholia they're talking about?
Thank you very much, Dr. Bono. I agree with you, and I think basically this is what we saw. They tend to have significant, basically, psychosomatic preoccupation here. However, the literature have always focused on the content of these psychomotor, on these basically preoccupation. Like if you go to the literature, they describe this as under the term of hypochondriasis, focusing on illness. Like it's just the content that defines the syndrome, the content of it's being preoccupied by health, physical symptoms. Well, it's a thought disorder. It's the fixated, repeated, non-contextual idea. No matter what the idea it is, if it's your health, we call this hypochondriasis. If it's something else, no, we should not be defining the thought process issue by their content. It can be a normal content. It can be a delusional content. But yes, most of them had actually, like many of them had actually some, preoccupation physical symptoms.
Thank you. I think our next question is from Dr. Schumann, our lead pharmacist at the State Hospital. Please go ahead.
I'm in trouble now.
No, that was a wonderful presentation. I really enjoy hearing it. My question was, I know every now and then you see about for, as a second or third line for catatonia or even for OCD, which you mentioned some OCD overlap is something like an NMDA modulator. And so just curious, I think I saw you mention lamotrigine once on one of the slides, but what about, I guess any experience with anything you saw about roles for something like amantadine or memantine?
We tried amantadine for one of those patients. I mean, again, like amantadine is a good medication used for the treatment of catatonia as an off-label. It's not a first line, not even a second line, but it's been increasingly used and recognized. Some of these literature even talk about being an augmenting agent. My experience with it was not good, but that's I cannot base my experience based on 1 or 2 patients. So
Oh, no, I appreciate it.
Yeah.
Thank you.
Okay.
We have a question from a medical student in Q&A. The question says, did you consider clozapine for case number 4 due to its ability to decrease suicidal risk? That suicidal risk in the studies, obviously in schizophrenia populations, but clozapine and its role in this, is it something that you think about, Dr. Mahgoub?
It's an excellent medication. I use it all the time. Sometimes when you get antipsychotic, this is my go-to medication when I see catatonia not responding to anything. Sometimes antipsychotic can make things worse. If we've had patients, when you try them on anything, they get more catatonic, it get worse. So clozapine is an excellent choice. It's an excellent thought for this patient. We did not try it.
Okay. Any other questions for our presenter?
One last word again on this again. By any chance, not suggesting the use of benzos for people with depression. We're talking about a variant of depression that might tend to respond to GABA agonists.
All right, I think Dr. Rabbani has a question. Please go ahead.
Okay, my question is about how come that certain benzodiazepines work but not others? Is there any explanation for that?
Thank you very much. I think that's a question that nobody was able to give a conclusive answer to in catatonia here. And in the same way, here it's same way in depression. They found that in depression, they found the triazolobenzodiazepine here seems to have a better response. In catatonia, that's not the case. I mean, I've heard some case reports occasionally talking about clonazepam working, even diazepam working. Day to day, it's only lorazepam that tends to work better. But I don't know. I think nobody was able to get a clear answer to that.
Thank you.
Okay.
Any other questions for our presenter? Well, thank you everybody for attending today's presentation by Dr. Mahgoub. I think it was a wonderful topic, and we're very, very happy that you were generous with your time and knowledge and joined us today. Hopefully we can have more collaboration in the future. Thank you very much, sir.
Thank you very much, and I'm happy to be here. Have a wonderful day.